There we go. Okay, so we're going to just go a little bit of an overview on head injury, talk about the clinical evaluation, diagnosis of TBI, some surgical decision-making indications for surgery, talk a little bit about critical care management of the head injured patient, including ICP or intracranial hypertension, then monitoring those patients, managing them, and then a little bit on future directions and other recent studies and trials that have been put out. This data are pretty old, I'll admit, but basically, head injury is a major public health problem. And as of 15 years ago, there were 2.5 million ED visits per year that included a diagnosis of head injury. Probably largely, and the increase is probably due to increased awareness, specifically of concussion, because the rate of concussion visits rose by 57% over the early 2010s or the 2000s. But hospitalization rate only raised by 10%, and death rate actually declined by 7%, probably because of improved care, but also because we're including more mild patients into the denominator. But regardless, it does contribute to a large number of ED visits. Only a small number of them actually wind up with hospitalization or death. Causes are varied and varied significantly with the population of interest. Falls are a very common cause among the elderly, but in younger folks, motor vehicle accidents or assault or even self-inflicted injury can be fairly common. The clinical evaluation, the most important thing when we're evaluating these folks in the emergency department is essentially the level of consciousness. And the GCS, or the Glasgow Coma Scale, is a quick and dirty way to summarize that with a single number, or in this case, or you can actually look at it in three numbers with three domains: the eye-opening, verbal score, and motor. And this is a key component of the clinical assessment for trauma patients after you've established that their airway is secure, they're hemodynamically stable, et cetera, et cetera. For us, actually, the most important component of it is the motor score, and that's because it's probably the most reliably reproducible part of the exam, and it's the one that's least confounded by other interventions. So, for example, sedative, you're going to close someone's eyes, and if someone's intubated, it's quite hard to have a conversation. But if you're intubated and even a little bit sedated, but you have a pretty mild head injury, you should be able to follow commands unless there are other confounding factors. So TBI is classified into mild, moderate, and severe based on GCS historically, at least. And this is sort of a hot topic in neurotrauma, that really GCS is an insufficient on its own to help to describe the degree of head injury, and talk a little bit more about that in a second. Vast majority of the patients coming to the ED are of mild TBI, and most of them don't require hospitalization, and often don't have anything on their head CT, just have essentially a concussion. And as a consequence, as you'd expect, long-term outcomes are much better in mild TBI than they are in patients with more severe head injury, and that's with regard to return to normal life, cognitive function, and psychiatric symptoms down the road. However, because there are so many more patients with mild TBI, there's a very significant societal burden given its greater prevalence. And so even though the patients, just have a mild TBI, they don't need surgery, they don't need an ICU, that doesn't mean they're going to go back to normal life. They can still have significant neuropsychiatric and cognitive dysfunction that can take months to recover and may never recover in some patients. So as a surgeon, why do we care about GCS so much, or a level of consciousness? And it's basically because the lower your GCS, or the less conscious you are, the more stuporous you are, the higher the proportion or the higher likelihood that you are to have an intracranial abnormality on a CT scan. And of those patients, more likely to have a intracranial lesion that requires surgery for evacuation. GCS is also useful, although imperfect, for trying to gauge what someone's long-term outcome might be. These are patients stratified into good, moderate, and severe disability and death in terms of recovery. And obviously, patients with more mild GCS, GCS 13 and 14, are much more likely to have good recovery than patients with much more moribund presenting exams. There's kind of a funky artifact of this graph. You can actually see that there's a lower proportion of patients. That's kind of the trend reverses for GCS 3 versus 4. You actually see that on the prior slide too, when you're looking at proportion of patients with intracranial findings or needing surgery. And that's because there are things that can confound your exam, and even in the highest quality research studies from which these data are derived, the exam can still be confounded by something. And so a GCS of 3 could be because someone has paralytics that aren't recognized. They could have sedation that's not recognized. They could have been hypotensive, or they could be hypotensive at the time of the evaluation. Although typically that's not when you want to do the evaluation. But all these things can confound your neurologic exam. Whereas a GCS of 4 means you are getting your exam, and it's not good. So that's just something to keep in mind when you guys are seeing folks, if anyone's going into surgery or emergency medicine or other trauma focused fields. So while I've beaten the drum about how important level of consciousness and GCS are, they don't tell you everything. And imaging is actually very, very important in head injured patients. And that's because patients with the same GCS can have very different intracranial pathology. So the first row of CT scans is patients with a GCS of 14. Patient on the left had a large epidural hematoma, went to surgery, had it evacuated, did fine. Patient here had a very small tentorial subdural. So this is the tentorium, which divides the cerebellum down here from the cerebrum up here. And you can see it's a little bit thicker on this side than it is on that side. So yeah, there's a little blood layering on that, but it's not a surgically significant finding, and it's probably not explaining the patient's altered mentation. They probably are just concussed. And so, this patient didn't need surgery and wound up doing fine. This patient on the right, totally normal head CT, no problems at all, wound up being intoxicated and metabolized and did fine. Conversely, patients on the bottom, this patient has a GCS of 3T, so no neurologic exam, essentially. But on the imaging, there's this large subdural hematoma that's largely extraaxial. And so basically what's happening here is the clot is pushing on the brain, but there's not much injury to the brain itself. And so after the patient was taken to surgery and had the clot evacuated, they actually had some degree of neurologic recovery. Contrast that with the patient on the bottom in the middle who has devastating brainstem hemorrhage. Nothing you do is going to unfortunately help this individual. And then the bottom right corner is a patient with, again, a normal head CT, highlighting the point that you can have a really distressing neurologic exam without intracranial pathology. So imaging really helps, is really important in teasing all this out. So essentially, if a patient in the setting of trauma has a depressed GCS or otherwise abnormal exam, a CT scan is indicated. Obviously, other factors such as age, mechanism of injury, high-speed motor vehicle accident versus ground level fall, for instance, use of anticoagulation and other decision factors can influence the decision to image. And obviously, there's a lot of things that go into this. So there are some decision rules that have been developed to help clinicians evaluating these folks in the emergency department decide, who really needs a CT scan. And they really bias towards maximum sensitivity with the sake of some imperfect specificity. So you want to make sure you're not going to miss anybody with a clinically important head injury, but you at the cost of scanning a bunch of patients who don't have any problems. Then over the last several years, there's burgeoning data that the use of blood-based biomarkers, some listed here, can help to identify with greater accuracy patients who will have a positive CT scan. And those numbers are also very important because they correlate with intracranial pathology and even long-term outcome for a lot of these patients. And so when we talk about imaging for TBI, we're talking about CT scans, and that's because MRI in almost every hospital is slower and not as much available. And to be honest, it's much more expensive and doesn't give you the extra bang for the buck. Isn't worth it in terms of the slowness and the cost. And then the results of the scan dictate the next step. From a neurosurgeon standpoint, the key question is whether there's an intracranial hemorrhage. Certainly, if there's an intracranial hemorrhage that's surgical, and by that I mean, is it creating lots of mass effect and displacing the surrounding brain? There's different ways to measure mass effect. One of them is the most commonly cited one, probably is midline shift, which you can see an example of here. You basically draw a line down the middle of the skull and measure the middle of the brain. And if it's shifted over typically more than 5 millimeters, the answer is it has the patient needs surgery in almost every circumstance. And there's some other things that you can look at on the CT scan to give you kind of a sense for whether there might be high intracranial pressure, although CTs are very imperfect for this. One of those is, swelling of the brain, compression of the spinal fluid spaces, such as the sulci around the convexity. So the convexity is sort of this part up here on the outside, or the cisterns, which are these CSF spaces down here surrounding the brainstem. So you can see there's a nice CSF cleft all the way around this brainstem here that disappeared several hours later as this hematoma blossomed. And so that brainstem is now unhappy because it's being compressed and all the CSF space around it has been um, filled with brain, which is not good. And when that happens, you can get a third nerve palsy. So that's why we are so attuned to the pupils in addition to the level of consciousness. And so you get a third nerve palsy, you get ipsilateral dilation of the pupil and down and out occasionally. Challenge with pupillary exam is that it can actually be very hard to get a reliable, objective, and repeatable exam from um, assessor to assessor, and that's especially true for patients with dark brown eyes. And so there's actually been a lot of work over the last decade to bring forward quantitative pupillometry, which sounds crazy, but it's actually quite useful because it gives you an objective and serially trackable measure of pupillary response. And we know that in patients with abnormal pupillary reflexes on quantitative pupillometry, there's a higher incidence of intracranial pathology, including higher incidence of intracranial hypertension. Now, when you're talking about, fixed and dilated pupils, the duration of that finding is really important. Someone who's got a fixed and dilated pupil for 10 minutes in the ED is obviously much more salvageable than somebody whose pupils have been fixed and dilated since yesterday in Alaska. And by the time they've gotten to Harborview, it's unfortunately 24 hours later. That person is much less salvageable, unfortunately. All right, so I'm going to shift gears a little bit now and just kind of talk about different kinds of intracranial hemorrhage. I'm sure this is stuff that most of you guys learned in clinical neurosciences, but just go through it again as a quick refresher. But basically, bleeding can happen anywhere to any of the compartments inside the head, from outside the scalp. You can exsanguinate from your scalp. It's highly vascular, to under the bone, outside the dura, epidural hematoma under the dura outside the arachnoid. That's a subdural, subarachnoid, intraparenchymal, intraventricular, etc. So, epidural hematomas are typically due to a fracture in the skull and or a tear in the middle meningeal artery that runs between the skull and the dura. There's a cartoon of that right here. And when there's a laceration to the middle meningeal artery, you can have high pressure bleeding under arterial pressure, which can actually forcibly dissect dura off the bone if it's high pressure enough, and that leads to accumulation of a blood clot that eventually puts pressure on the brain. The classic board style question for these patients is that they have a lucid interval, so they'll be like knock unconscious at the time of the incident and then come back to, and then gradually become increasingly somnolent. Although that's not something that we see routinely in clinical practice. Epidurals are a lot more common in young patients because the dura is not as stuck to the bone. In older patients with age, the bone gets really adherent to the dura, and so it's less common for you to see that bleeding into the epidural space. Subdurals are the next layer down. The classic description again is that it's due to a torn bridging vein, such as this here. Although in high mechanism trauma, such as motor vehicle accidents, assaults, etc., it's often due to injured vessels and or lacerations right on the surface of the brain, leading to high pressure bleeding into the subdural space. When bleeding blood accumulates, it can put pressure on the brain and require surgical evacuation if it's sufficiently large, creating mass effect and or causing focal neurologic deficits. Just another cartoon. Here's a dura underneath an epidural and the dura outside a subdural. Both of them push the brain. Subarachnoid hemorrhage is the next layer down. It's this web-like space where there's interdigitations into the sulci, and so that's why you have these wispy fingers going in between the gyri. Trauma is the #1 cause of subarachnoid hemorrhage. Aneurysms are the most common cause of non-traumatic subarachnoid hemorrhage, but trauma overall is the most common cause. And typically tends to be not something that we worry about too much if it's an isolated lesion without an associated subdural or intraparenchymal hemorrhage causing significant mass effect. Intraparenchymal lesions themselves are often due to essentially a bruise on the brain. So, your brain's actually floating inside the skull, inside the spinal fluid, which provides a cushioning and suspending force. But with rapid deceleration, the brain can continue forward and strike the posterior part of the anterior cranial vault, which basically leads to a bruise here, and then that can bounce back, get you a contra coup injury. It's the classic coup contra coup finding, and that's because the brain's momentum forces it to continue in spite of the rapid deceleration of the skull. And then with diffuse injuries or like rapid acceleration, typically high-speed motor vehicle accidents, ejected passengers, motorcycle accidents, things like that. The rapid rotational forces can put tension on the axons connecting part A of brain to part B of brain, leading to this kind of starry night speckled appearance. It's really hard to see on CT scan. This scan shows like a couple of like subtle things that kind of go along with it. Like there's some blood in the white matter areas of the brain, but it's really hard to see on CT, and you often need an MRI to really see the diffuse patterns of microhemorrhage that come with this. And one of the complicated things about head injury is that you don't have to pick just one. You can have two of them, you can have three of them, you can have all of them all in the same patient, and so you kind of have to take it all as it comes. All right, I've been rattling along for what, 20 minutes. Do you guys have any questions about anything so far? If not, I can keep going.
I have a quick question about diffuse axonal injury.
Yeah,
Is it diffuse in the sense that like literally the whole brain is involved, or is there a portion of the brain that's like affected more and then the rest of the brain is fine?
that's a good question. It can be either way. You can have diffuse DAI that essentially affects both hemispheres of the cerebrum, the descending white matter tracts down to the um, uh, down to the brainstem and into the brainstem itself. Um, to be honest, diffuse axonal injury is probably a term that's falling out of favor in being replaced with like shear injury, which essentially is maybe a little bit more precise because, as you allude, it doesn't have to be diffuse everywhere. It can be um, a little bit more focal. Um, although it tends not to be like a dot right here. Usually, it's a constellation of microhemorrhages in a geographic distribution. It's a good question.
Thank you.
Okay, so let's talk about managing these patients. Um, So, broadly speaking, I like to think of two categories of neurologic injury. There's the primary injury, which is basically the mechanical trauma to the neurons, vasculature, et cetera, at the time of the accident. And that's unfortunately, with our current technology, largely cat out of the bag sort of stuff. We can do our best to prevent further secondary injury, which is the stuff that comes after the fact. But we can't do a whole lot to prevent the primary injury other than encouraging people to wear seatbelts, helmets, not speed, et cetera. Secondary injury is caused by things that cause the brain to get sicker after the initial trauma, and that can be due to hematomas creating stress, intracranial hypertension as they accumulate. It can be due to swelling of the brain causing an intracranial ICP, which can lead to metabolic starvation, such as ischemia or hypoxemia if patients have high ICP and or if they just have systemic illness, so if they have hemorrhagic shock, that can also cause secondary injury, or if they code, heaven forbid. It's a very significant negative prognostic finding. So, when it comes to surgical decision making, the goal is really to alleviate mass effect, at least in the upfront acute evaluation period in the emergency department. So that's evacuating hematomas and providing space for the swollen brains as well. Now, when patients with refractory elevations in ICP, we can eventually get to surgical decompression, but it's not the first tier management, and we'll talk a little bit about that in a second. Generally speaking, patients require surgery for large or enlarging hematomas that are causing mass effect. So midline shift, cisternal compression, herniation syndromes, blown pupil. In general, patients do not require surgery for small, stable hematomas that aren't causing significant mass effect. So maybe a millimeter or two of midline shift. They're only 2 to 3 millimeters in thickness, et cetera. Patients wide awake. Again, traumatic subrectal hemorrhage typically doesn't need surgical intervention. Diffuse injuries, so there's like not a big clot to remove, but there's sort of diffuse brain edema or swelling. As long as the ICP is okay, we tend not to recommend surgery. But if the ICP does start to climb and is not responsive to medical management, this should say not responsive to medical management, um, then that would be an indication for surgery. Again, just kind of harking back to the importance of imaging, GCS 14, both patients, same GTS level of consciousness, but this one went to surgery for evacuation of the large epidural. So, all of this stuff we do in neurocritical care or neurotrauma is predicated on really good basic critical care. And that's, I can't say that how important that is, because some of the strongest predictors of poor outcome among head injured patients are hypotension and hypoxemia. And that includes early episodes in the field, such as hemorrhagic shock, or late events in the ICU, like pneumonia and sepsis leading to hypoxemia and hypotension. So you have to be really aggressive in making sure these patients are kept essentially normal with regard to blood pressure and maybe a little on the high side with regard to blood pressure and oxygen saturation. In patients who don't have a clear mass lesion that requires evacuation, but they have a depressed neurologic exam, we classify them as severe because their GCS is less than 8. There's a relatively high risk of intracranial hypertension, which again places them at risk for secondary injury because you're starving the brain of nutrients because the brain is swelling so much. Reduce that basically can be treated with medications, but accurately treating and managing the ICP requires a monitor. And so we place ICP monitors fairly aggressively in patients with depressed neurologic exams so that we can ensure that ICP is not a problem. So intracranial hypertension or intracranial pressure is essentially determined by the stuff that's inside the skull. And so in a healthy person, that's the brain, cerebrospinal fluid, and intravascular blood, like arterial blood and venous blood. And if any of those compartments gets bigger, so you have brain tumor that's rapidly growing, or there's massive cerebral edema from hypertension, or there's hydrocephalus, there's a new compartment. So there's a new blood clot, like a big subdural or epidural, that can cause the pressure to rise. So typically there's some amount of compliance. So basically you have this curve plotted here. On the x-axis is the intracranial volume that's being added in the form of new brain from cerebral edema, blood clot from hematoma, or CSF from hydrocephalus. You can actually compensate for it to some extent for a while. But then unfortunately the compensatory mechanisms gradually get depleted. And that leads to a rapid linear relationship between increased volume of lesion and intracranial pressure. And that's where you start running into really problematic issues with herniation and ischemia. So the goal is to try to keep patients down here where you have a little bit more of a compliance and reasonable compensatory mechanisms. Managing intracranial hypertension is done with a tiered approach. So we start with kind of the least invasive, most trivial things, and then work our way up to the most aggressive and most morbid things. So the easiest thing to do is you just raise the head of the bed. And that's because it allows gravity to work on all the venous blood in the head down to the chest. That encourages venous drainage, improves the ability of the brain to kind of shunt blood out of the head through the venous system and can actually have a pretty marked effect on intracranial pressure. And then from there, we escalate to more aggressive things, just picking some examples of mannitol, hypertonic saline, which are osmotic agents that draw fluid out of the brain. And then ultimately, you get to decompressive craniectomy, which is the quote-unquote definitive treatment, although it's sometimes not definitive. Patients can still have intracranial hypertension once the bone has been removed, but it's the only solution that fixes the pressure-volume equation by increasing the volume. And this figure on the right here is just showing schema from a trial, showing like the complicated options that you have to go through, and you kind of work through your tiers until you get to more aggressive treatments. Here are some of the things that we use in Harborview, and this is kind of my favorite slide from this talk, and just kind of like the simple things you can do. So position the head of bed, make sure the patient's analgesied and sedated, treat fever, treat seizures. A lot of these things, honestly, these are just basically making sure blood flow is optimal. So in this case, head of bed up, neck neutral, make sure that blood can drain. Analgesia and sedation, make sure that metabolic activity is suppressed. And since metabolic activity in the brain is coupled to blood flow, if they're not metabolically active because they're sedated, that reduces blood flow. It also helps patients tolerate the ventilator, can improve ventilator synchrony, which reduces intrathoracic pressure, which again allows blood to flow out of the brain into the chest and improves ICP. So on and so forth. Tier two, getting into things like mannitol hypertonic saline, literally pulling fluid out of the brain. Paralytics, especially for patients who have poor vent synchrony despite aggressive sedation. CSF drainage, so you can take a little bit of CSF off these patients. We tend not to use that as a first line of treatment here at Harborview, but there are centers that put EVDs in upfront for all these patients. There's some debate in literature about what the right approach is. And then you kind of work your way up to more aggressive things like pentobarbital coma, which is perhaps more effective in patients who have some ongoing metabolic activity, or i.e., they have ongoing activity despite high dose sedation on EEG. Pentobarbital is sort of like the ultimate expression of sedatives, because you can basically turn off the brain, and that is thought to help reduce blood flow and serve as a neuroprotective action. And then we talked about decompressive craniectomy. So let's talk a little bit more about decompressive craniectomy. Over the last 15 years, there have been two big landmark studies that have changed practice, as they've called into a little bit of question the benefit of the surgery, at least in terms of improving neurologic outcomes for survivors. And while we still do it for intracranial hypertension, it's not something we reach to as aggressively as we used to. So the first of these was published in 2011. It's called the DECRA trial. This study looked at early decompressive craniectomy in patients who didn't have a subdural, no mass lesion, and they had ICP over 20 for 15 minutes, which from a practical standpoint is actually a very aggressive trigger to remove the bone flap, because I'm sure any of you who spent some time in the neuro ICU knows it takes a few minutes to get the mannitol to the bedside, spiked and going. And so even though these patients might have had high ICP, it's not clear that they were actually refractory and out of other options. And in fact, you can see that on their ICP tracings post-randomization, which is the dotted line. Both groups had reduction in ICP below the randomization threshold, both the surgical group and the non-surgical group, again, suggesting that it's not really refractory ICP that you're studying here, but just really aggressive early decompression. And so while the ICP reduction was much more profound in the decompressive craniectomy group, the surgical outcomes weren't any better. In fact, they were shifted towards a greater proportion of patients having poor outcomes. Now, this study was criticized for some of the things that I've alluded to, namely the fact that the randomization threshold is pretty low, pretty aggressive. So there's a follow-on study called Rescue ICP, which I think more directly studied the question of refractory intracranial hypertension, which they defined as greater than 25 millimeters of mercury for over an hour. And they found that surgical patients were more likely to survive to discharge or survive to 6 months, but they were not more likely to have a favorable outcome. And so this is the distribution of outcomes plotted with bar graphs here. Brown is dead, and blue is good. And you can see that there's a significant decrease in mortality, but those patients who have increased survival tend to be those in a vegetative state or lower severe disability, maybe some increase in upper severe disability. And this is, I think, where like a little bit of the eye of the beholder, or the patient's perspective or family's perspective, can be really important, because outcome is really dependent on what the patient and family values. So just to kind of show that line again here between orange and yellow. Orange is lower severe disability. That's someone who basically needs 24-hour care. And yellow is someone who is dependent on ADLs but is safe alone for 8 hours. And so if your patient is someone who might value being moved into this category here, then yeah, surgery is probably worth doing. But it's not clear that surgery is going to improve your likelihood of getting back to upper good recovery, which is being a med student, for example. And then I lost a slide here. Is it still there? No. Okay. So then there's some additional neuromonitoring techniques that are kind of coming out to the forefront. So one of the concerns with intracranial hypertension is that you wind up depriving the brain of blood flow, because the pressure in the head gets so high that it retards inflow of oxygenated arterial blood. And so a bunch of people smarter than me started making these electrodes that basically measure the partial oxygen tension of brain tissue and allows you to use directed treatments to reduce brain tissue hypoxia. And so there's been a couple of randomized trials on this. One called Boost 2, which was published a few years ago, showed that you can actually move the needle when it comes to the amount of time patients have brain tissue hypoxia. And there was an encouraging but not statistically significant signal towards improved neurologic outcome with a reduction in mortality and actually a pretty impressive improvement in favorable neurologic outcome among patients managed with the brain tissue oxygen plus ICP arm versus patients who just had ICP alone. The caveat is this study wasn't powered to detect a clinically significant difference, and so they don't have the numbers to test this with p-values and all those sorts of things, which is why Boost 3 is currently ongoing, and we're enrolling patients for that here. There was a recently published study called OxyTC that looked at this in France, and so they randomized patients to ICP monitoring without brain brain tissue oxygen versus without, and they didn't find any significant difference in this in their overall cohort. There are a lot of nuanced critiques to the methods of this study compared to those of Boost, but suffice to say they don't see a difference here unless you parse things really finely in one of those post hoc analyses that are always so challenging to interpret because they aren't necessarily the goal of the study, and they can certainly introduce a lot of confounding. But they found that among patients with high intracranial pressure, there was a trend towards significant, or there was a statistically significant difference in outcome among patients who had PbO2 monitoring versus those who didn't. So there may be a subgroup of patients for whom PbO2 monitoring is more helpful than others. Future directions. So what are some other things that are kind of active areas of research in neurotrauma? I think for me, one of the biggest questions is, who really needs a monitor? We put ICP monitors in pretty aggressively for patients with depressed GCS, but up to half of patients never really have high ICP that needs treatment, or even more in some circumstances. And so that's a lot of patients who are subjected to the invasiveness risks of drilling a hole in the head who don't have a chance to benefit because they never have ICP. So can we better figure out who those patients are before we drill a hole in the head? Are there other intracranial monitors that can give us additional information, such as depth and strip electrodes on the scalp or on the brain surface or in the brain parenchyma? Cerebral blood flow monitors looking at autoregulation, microdialysis, looking at actual like metabolic markers of ischemia, like lactate versus pyruvate ratios, things like that. Continuous EEG is really helpful in neurotrauma patients. Among severely head injured patients, up to a third will have seizures identified. And then blood biomarkers. So we know that CT, they're very helpful at predicting whether CT scans are going to be positive or negative, but the less is known about how they can be used to guide decision making about what to do for these patients. And then, as I said before, all of this is predicated on good critical care, and so this really depends on better ABCs, making sure that patients' bodies are healthy so that their brain can recover. I want to close with a couple of other points here. One is this idea of multimodal monitoring. And so while we've talked a lot about intracranial pressure, brain tissue oxygen, et cetera, I really want to hit home the point that there's no single magic number, and you shouldn't be falsely reassured or alarmed by monitoring data. You have to kind of take the whole picture. And just as an example, patients with large temporal contusions, so like right down here, they can herniate medially and pick off their brainstem, even if they have relatively normal intracranial pressure. And then conversely, patients who have other diseases such as idiopathic intracranial hypertension can walk into clinic, have a pleasant conversation with you about how bad their headaches are because they have IIH, and they have an ICP of 40. And when in healthy patients, when you have Valsalva, so you bear down really hard, you go to the bathroom, you can drive your ICP up into the mid double digits, easy, no problem. And so again, ICP is not the whole thing; it's ICP combined with all the other things. And there's probably something about the injured brain that makes it more sensitive to intracranial pressure changes. And that really care of the TBI patient requires integrating all of the data, including the clinical exam, imaging, monitoring data, and that includes ICP, EEG, brain tissue oxygen, vital signs. What's the blood pressure? What's their entitled CO2? What are the lab values? What's their sodium, et cetera? Just kind of taking all this together into one integrated clinical picture that guides your decision making for these patients. The other point I want to make is that recovery is really slow. And so just because patients have a not encouraging clinical picture 2 weeks out from injury doesn't mean they're never going to have a good clinical picture. So, here's a graph of outcomes, and at 2 weeks, really nobody had. Uh, this is for patients with severe TBI, by the way. Nobody really qualified as good recovery. But then when you get out to 3 months, you start to see it. Then out to 12 months, you really start to see it. And these trends do continue past 12 months. And so it's a long game. So while there are some patients where it's helpful to be kind of pessimistic early on, so for example, the patients whose scan I showed you earlier with the massive brainstem hemorrhage, whose GCS was 3T with fixed pupils, like that's a bad situation that recovery is unlikely to happen from. But patients with less black and white clinical pictures, it's worth giving them some time because they can really surprise you, and we see that in our resident trauma clinic all the time. And then a couple other things to just talk about, things that have been tried that haven't worked. Steroids, hypothermia, and antifibrinolytics, so TXA, essentially. One, there's a study of steroids around the turn of the century called CRASH, and they randomized patients with TBI to steroids versus not, and they found that patients with steroids were more likely to die. And so the short answer is steroids harm patients with TBI, and they shouldn't be used specifically to address um, uh, brain edema from swelling, brain edema from trauma. Now that said, if there's another compelling reason to give it, say they have like an adrenal crisis or they have ARDS or something, like, yeah, sure, give them steroids for that other reason, as long as you think the odds of benefit are and survival from that disease or treatment are better than the odds of harm from head injury, which, while significant, was actually fairly small in terms of risk ratio. Cooling. So there's, well, this slide's a little out of date. There once was thought to be robust evidence for neuroprotection after cardiac arrest. There's some disagreement on that now. Certainly avoiding fever is good, but there's not really robust evidence for it in head injury. There have been a lot of studies looking at this. Some studies were halted early because of harm. This study was not halted early because of harm. It was one of my favorite studies on the topic because people were sort of criticizing the literature, saying, well, maybe you're just not cooling them early enough. So these investigators put a bunch of ice cold saline bags in paramedic rigs and cooled patients in the field and kept them cool until they got to the hospital and for several days afterwards. And while there was no difference in intracranial pressure between them, there was also no difference in outcome. So there's really no compelling evidence at this point that cooling patients is at least beneficial for the long haul. And then TXA. So TXA we know is actually quite good in patients who are at risk for at least a hemorrhagic shock. So that was in CRASH 2. CRASH 3 was a follow-on study looking at TXA in patients with TBI. Theory being, if there's bleeding in the brain, TXA might help it stop faster. The study is a little bit hard to interpret, but the take-home point from my standpoint is that there's no effect in severe TBI, and so these are the patients with severe head injury. There are no increased risk of or no rather decreased risk of poor outcome. They found a significant reduction in head injury mortality among mild to moderate TBI when you give the drug early, so within the first couple hours. But while it's a pretty impressive looking risk ratio reduction, it's actually only a very small absolute risk reduction of only 7.5 to 5.8%. So what is that, like 1.7%? And the other thing is that's TBI related mortality, but not all cause mortality. There's no difference in all cause mortality. And I don't know about you, but I don't care why I die. I just care that I die. And so this for me is not really a patient-centered outcome. And furthermore, if you thought there was maybe some mortality benefit among mild to moderate head injury patients, you'd be thinking, well, maybe their head injuries just aren't as bad and they're going to have better neurologic recovery. They didn't see that either. There's no difference in neurologic outcomes among the survivors. So while there is some, if you parse the data, there's maybe some signal. It's not something that I think has compelled most people taking care of TBI patients to incorporate it routinely. And there was another study that sort of showed the same thing. They had 3 groups of basically two getting TXA and one getting placebo, and they found that there was no difference in outcomes or mortality. The only caveat is that about half the patients, when they got to the ED, actually didn't have TBI. And so if there is a treatment effect, it's possible that it was diluted by the fact that half the patients didn't actually have TBI. But this is a pragmatic study because you're talking about starting a drug in the field. You don't know if someone has a head injury until you get the CT scan. Again, the importance of imaging. So my take-home thoughts on TXA or antifibrinolytic therapy are that there's really not any evidence of harm. So there's no increased risk of like PEs or cardiac events or things like that. So if there's another compelling reason to give it, you should. Again, hemorrhagic shock. But I wouldn't use it just for their TBI. Okay. And then finally, just close with a bit of a review. And if there's a couple of points that you guys take home from today, these are them. One is that the GCS, level of consciousness, and pupillary exam are really important, but imaging is also quite valuable. And it's taking all of this data together, not just the exam, not just the imaging, not just the ICP, but really considering all of the information together to come up with a comprehensive clinical picture and making a plan based on that, not just one number or one CT scan. And the other thing that's I think really important is that recovery is really slow and that we should be humble about our prognostication efforts outside of the most extreme of cases. And we shouldn't be discouraged by what appears to be glacial progress in the first several weeks. And then last but not least, this is all really, really important based on good critical care. And so if patients aren't being cared for with good pulmonary hygiene, extubated in a timely fashion, et cetera, mobilized as appropriate, like the outcome's not going to be as good. So that is all that I have. I'm happy to take questions either now here in the chat by type in, or you can send me an email if you prefer.
I have another question really quick, Dr. Bono.
Uh-huh.
Sorry if you already mentioned this, but ultrasound, like transcranial or cranial ultrasound, I've never seen it really used like for monitoring purposes outside of the OR. I'm curious if that's something that is used anywhere and or yeah.
Yeah, so that's a good question. Ultrasound can tell you a lot of different things. There's there's something called the optic nerve sheath diameter, which I'm sure you guys have heard of. It's basically the dural sheath inside the head is continuous with the optic nerve sheath in the eye and the globe. And so if you have a high pressure inside the head, it can transmit into the eye and cause dilation of the optic nerve sheath. So that's something that that's one of the things that actually I'm doing a study on, try to test whether like how well that really predicts intracranial pressure and whether it gives you added value over the stuff that you already have from CT scans and clinical exams. Ultrasound can also be used. There's some kind of promising research on putting an ultrasound probe up on the head and getting a sense for, what's the midline shift? Is there a giant subdural? Obviously, it's not going to be nearly as sensitive as a CT scan, but it can help. Assuming patients, you have a powerful enough ultrasound, which is one caveat, and two, patients' skulls not too thick. Some patients with TBI, especially penetrating head injury, patients with high volume subrectal hemorrhage as part of their trauma, which is a little unusual, but it does happen, that can be at risk for vasospasm. And so we do sometimes use transcranial Dopplers to measure blood flow velocity and look for vasospasm, which is a whole other talk. If you guys you've probably seen that from one of the vascular folks, but that can be useful too. And then, patients who've had a craniectomy, you can actually get a really good look at the brain and see all the way to the other side. And that can be helpful, especially because patients with craniectomy are at risk for post-traumatic hydrocephalus. And so we can look at the ventricles pretty easily and see how the trends are over time.